Mycobacteria, the one that we're going to really concentrate on as far as mycobacterial infections is tuberculosis. And this will be covered also in the internal medicine sections. There are other mycobacterium that will cause infections, but we're going to concentrate just on TB. In this country, their reservoirs for tuberculosis include immigrants who come over with TB. Also look for poor, crowded conditions. Certainly the HIV population is also one that is a reservoir for TB, and the elderly. Children will get it sometimes from like grandpa who has TB and is spending a lot of time with the kids and coughing up a bunch of stuff. The disease starts off with the primary complex, which is a local lung infection. You can have some hilar adenopathy. You can have a latent infection in which you have a reactive TB skin test, but no other findings, and also absent radiographic findings. Skin testing, that's a common question that they'll ask you. And skin testing, the best test to do is the intradermal PPD. The skin prick test, the tine test is not as good as the intradermal PPD. It's the Mantoux test, and it's really a measure of delayed hypersensitivity. You're not going to turn positive right away. It usually takes about 4 to 8 weeks after exposure and inhalation to turn positive. A positive reaction, and here's a good test question. Positive reaction depends on certain circumstances. So you can have a positive reaction at 5 millimeters of induration. It's not redness, it's how much bumpiness there is. So it can be positive at 5 depending on circumstances, or 10 depending on circumstances, or 15 depending on risk factors. A patient that has absolutely no risk factors, you consider it positive greater than 15. A patient that has several risk factors is a high risk for TB. It may be positive at less than 5 or greater than 5 millimeters. The best is to get a positive culture, and that would be a sputum culture. Unfortunately, in children, sputum cultures are very hard to obtain. When a child coughs, they usually bring up a lot of saliva too, as opposed to an adult. An adult will give you an unlimited amount of sputum, particularly if they have like TB. In a child, it's a little harder. So the best test to actually get sputum in a child is the morning aspirate of the stomach. So early morning NG aspirates. What happens is at night the child coughs, swallows, and it stays in the stomach. So if you get them right early in the morning before they start moving around, you slide an NG tube in and suck that stuff out and put that for culture. You need to do that 3 days in a row, and that would be a good way to get a culture in a child. However, remember that if a culture is negative, doesn't mean that you don't have the disease. Most children will be asymptomatic with TB. Infants less than 1 year of age are more likely to have signs and symptoms, and it occurs early on. Occasionally, you can have low-grade fevers, cough and malaise, and then they get better. Reactivation in children is rare, but if it does occur, you can count on it happening around adolescence. Some patients will have extrapulmonary manifestations, and again, those manifestations depend on where the reactivation or the extrapulmonary site is. So for example, children can have problems with recurrent ear infections. If it's up in the ear area, they can have laryngeal reactivation or extrapulmonary site laryngeal, which can cause a persistent cough. It just depends upon where this site is that will then determine the symptoms. Primary pulmonary disease is usually a localized nonspecific infiltrate, and there'll be a large adenopathy compared to the size of the infiltrate. If it's large enough, it can actually compress airways and lead to atelectasis. But most of these resolve on their own. Extrapulmonary manifestations, we can have it go into the bloodstream and then spread everywhere, and that's what we call miliary TB. Then it can spread to lungs, to the spleen, and you see multiple areas where the TB has spread, and on histologic exam you see an organ that's completely infiltrated with the TB. TB meningitis is a specific one that you need to know. They like to ask that one. The reason is you need to know the CSF findings for TB meningitis so that you can actually determine treatment. Treatment will consist of your anti-tuberculous drugs, but if TB meningitis is the case, you also give them steroids. Typically you don't give steroids for TB, but you do if they have TB meningitis. Latent TB, what do you do with that? So this is the child that has a positive skin test and has negative X-ray findings. These people will get INH for 9 months. That's how you treat them. So positive skin test, negative X-ray, which would be the next step, start INH. If they have primary pulmonary disease, you always treat with more than one drug. Always, because there's more and more resistance to TB. And like I said, you can give steroids for TB meningitis. The BCG, not used much in the United States. It's not a routine vaccine. You do need to remember that with BCG, you can have a false positive reactivity for a short amount of time after administration of the vaccine. So it's only really recommended for people who have close exposures or long-time exposure. It's recommended if you have continuous exposure to a resistant strain, but it is contraindicated if you have immune deficiencies. Perinatal TB is a completely different subset. Sometimes the mom will have TB, and what do we do with the baby that's just been born? The first thing is the mother has a positive PPD. You need to get a chest X-ray on the mom. If the chest X-ray is negative and everything's fine, then have the baby and the mom go back together. If the mother has suspected TB at delivery, you have to separate them, the baby from the mother, until you work up the mom. If the chest X-ray is positive, then you have to get a sputum culture, and you keep the baby and the mom apart. If the mother has actual disease, then you have to treat the baby with INH, okay? But you can put the mom and the baby back together again. You do this with the INH until the mom is culture negative for 3 months. Then you have to skin test the baby. If the baby is negative, you can stop the INH. Don't forget, once you start antituberculous therapy, very quickly the patients stop being contagious. If the infant is, after these 3 months, if the infant is still positive, then you have to continue INH for a full 9 to 12 months.